Postpartum and pregnancy medical complications. Step 2CK rapid review using strict next best step logic. Section 1, hyperemesis gravidarum. The core clinical features of hyperemesis gravidarum are severe, persistent vomiting, leading to more than a 5% loss of pre-pregnancy weight. You'll often see this accompanied by severe dehydration, orthostatic hypotension, and sometimes even a mild transaminitis. Notice the key lab pattern here, particularly ketonuria. Prolonged hypoglycemia from inadequate oral intake leads to ketones in the urine, and that's your absolute indication for hospital admission. You're also going to see a hypochloremic metabolic alkalosis, hypokalemia, and hemoconcentration. Your next best step is hospital admission for IV fluids, antiemetics, and electrolyte correction. And remember this absolute rule: you must give Thiamine before dextrose to prevent Wernicke encephalopathy. Section 2, pregnancy liver disorders. Let's compare 3 very distinct liver pathologies. For intrahepatic cholestasis of pregnancy, or ICP, the key clue is intense third trimester generalized pruritus, especially on the palms and soles with absolutely no rash. It's driven by elevated bile acids, comes with a risk of intrauterine fetal demise, and you manage it with ursodeoxycholic acid, antihistamines, and usually delivery by 37 weeks. Contrast that directly with HELLP syndrome, which hinges on hypertension or preeclampsia symptoms, hemolysis, elevated liver enzymes, and low platelets. Finally, we have acute fatty liver of pregnancy. This involves microvesicular fatty infiltration causing nausea, right upper quadrant pain, profound hypoglycemia, DIC, and fulminant liver failure. For AFLP, the immediate next best step is delivery and supportive care. Section 3, postpartum infections. Postpartum endometritis is a polymicrobial infection of the uterine lining, and it's heavily associated with cesarean deliveries. Other major risk factors include intraamniotic infection, prolonged rupture of membranes, GBS colonization, and operative vaginal delivery. Look for a patient presenting with a fever starting more than 24 hours postpartum, accompanied by uterine fundal tenderness, lower abdominal pain, and purulent lochia. The diagnosis is clinical, so you do not routinely need blood or endometrial cultures to initiate treatment. Now contrast the localized signs of endometriitis against septic pelvic thrombophlebitis. Endometritis gives you that distinct fundal tenderness we just talked about. Septic pelvic thrombophlebitis, on the other hand, lacks clear localizing signs entirely and acts strictly as a diagnosis of exclusion in a persistently febrile patient. Let's dig into septic pelvic thrombophlebitis. This is an infected thrombosis of the deep pelvic or ovarian veins, often driven by cesarean delivery, pelvic surgery, endometritis, or just general hypercoagulability and venous dilation. You'll recognize this when the key clinical clue shows a persistent postpartum fever despite the patient receiving broad-spectrum antibiotics alongside a completely negative infectious evaluation. The next best step treatment algorithm starts with IV clindamycin and gentamicin to cover gram-positive, gram-negative, and anaerobic bacteria for endometritis. If there is no clinical improvement after about 48 hours, you need to evaluate for things like an abscess, retained products, wound infection, drug fever, or septic pelvic thrombophlebitis. If it is SPT, your absolute next best step is adding anticoagulation to your broad-spectrum antibiotics. Section 4, pelvic and urinary complications. Postpartum urinary retention is driven by pudendal nerve injury from perineal trauma or bladder atony, heavily associated with primiparity, regional epidural anesthesia, or an operative delivery. You should suspect this immediately if a patient cannot void within 6 hours after delivery, or if they present with small volume voids, incomplete emptying, and dribbling. First-line management is strictly conservative. Because the bladder atony is a self-limited condition, the next best step is intermittent bladder catheterization until normal detrusor tone naturally returns. Contrast that painless atonic presentation with pubic symphysis diastasis. This presents with severe suprapubic pain that radiates to the legs, exquisite pubic tenderness, and real difficulty walking. Crucially, though, the neurologic exam remains completely intact. Despite the severe pain of a diastasis, your next best step is strictly conservative. Manage this with NSAIDs, physical therapy, and pelvic support. Section 5, Sheehan syndrome. Sheehan syndrome results directly from an obstetric hemorrhage complicated by profound hypotension. That acute drop in blood pressure causes an ischemic infarction of the anterior pituitary gland, which is incredibly vulnerable because it's already enlarged and highly vascular during a normal pregnancy. The timeline tracks from that initial hypotensive hemorrhage to the critical early exam clue, lactation failure due to a drop in prolactin. This eventually progresses to late multihormonal deficiencies, causing amenorrhea, hot flashes, vaginal atrophy, fatigue, bradycardia, anorexia, weight loss, and hypotension. When you identify this cascade, your absolute next best step is replacing the deficient hormones individually. And as a strict management rule, always give glucocorticoids before levothyroxine if there is any possibility of an ECTH deficiency.